Thank you, Mr. Chairman, and thank you for all coming. It's wonderful to see the auditorium not full, but pretty close to full. So here we go. No conflict of interest to declare. Somebody said mortality looks at obesity. Mortality data looks at obesity. Is that a title? But we'll see what we can do along the way. But thank you for coming. I need to thank very much the whole team of QASM and all that they do. And names are there. I hope you'll talk to them during the day, encourage them during the day, and thank you so much to everybody who's put so much into it. Team. What is QASM? So this is just for those of you who don't know much about it. I'm just going to do a very quick overview. It's an audit of surgical mortality. It really is a peer review audit, and 100% of public hospitals, 100% of private hospitals, and 100% of surgeons participate in Queensland. Not quite so in other states, but let's say rah-rah to Queensland in this circumstance. What do we do? Well, we collect data. You think, what a boring thing. Sorry, Kirstine. But we collect the data and then we analyse the data. And again, the most important thing for us as surgeons, us as clinicians, us as clinical nurses and therapists, allied health, etc., is to learn from the data. And our aim has been to make this a very and most significant part of the QASM process. Remember that all our data comes as a peer-reviewed process and is organised in a peer-reviewed way. So the surgeon produces a surgical case form, returns it to QASM following a death. It's de-identified then and sent to a first-line assessor. So 100% of the surgical deaths in Queensland have a first-line peer-reviewed assessment. De-identified, it's double-blinded. Of those, the first-line assessor may say, I think it needs to go further, there needs to be a more forensic assessment of this, and so it goes to a second-line assessment. Again, peer-reviewed, de-identified, but that's only about in 14% of cases. What else do we do? Well, we work on things like today. Seminars have always been a very useful part of our learning process, and we hope you will learn by the feedback that comes through the many speakers today. Learning by feedback, but we've also had great encouragement from presentations, and we've been asked to present across and around the nation, and in fact across the Dutch, New Zealand for those who can't remember. And again, publications has been an important part, we believe, of what we do, and some encouragement about another one of those even in the last 24 hours. So learning by feedback is our reason for living. We looked at the data yesterday again, just moved past 8,000 cases on the QASM database. Only 10% obesity was a comorbidity. So you think, well, what's all this about today? Well, you'll hear more about that during the day, but 8,000 cases. So the team have been amazing in putting so much work into those 8,000 cases. Again, 14% second-line assessments. And if we look at what the assessors said, only 9.4% of all those cases have had a clinical incident, something that needs to be considered carefully, some area of concern or some adverse event. 9.4%. So, in real terms, less than 10% of cases have had a clinical incident involved in their care in the surgical patient that died. And the most common clinical incident, isn't this interesting, the decision to operate. And for the surgeons in the room, and there's many of us, that sometimes we see as the smallest part of our decision-making process. Surgeons need to surge, don't they? We always want to surge, don't we? But sometimes the decision to not surge seems to be the most important part of this process. So we look at a lot of qualitative data, and we're working on a fairly big walk through that arena at present. Question 25 in the surgical case form is the source of much information. So it asks the question, would you have done anything differently? And out of all that data, we're going to look very closely at where can we learn from that data as well. Just pulled a couple of figures this week to remind you that it really does affect us as surgeons and clinicians. You know, if obesity was marked by a surgeon or a peer as comorbidity, then the age of death is very different to if obesity was not a factor in that process. That's a fairly significant difference, isn't it? I'm not going to push you into RRs and all the other things today, but there's fairly significant difference. If we looked at the length of stay in the two, however, there was very little difference. Obesity and post-operative complications, 53 versus 33%. So again, a fairly significant and fairly cost-important factor in the whole process. And these five, and I'm not going to give you percentages, but these 5 thoughts came out of looking at our 8,000 cases. Just look at them for a moment. Double the rate of unplanned returns to theatre if obesity was a comorbidity. Double the rate of surgical site infections. Higher rates of post-op complications. Higher rates of unplanned ICU. Higher rates of delay in surgical diagnosis. So there's lots to think about. There's lots to talk about today. We hope it'll be very profitable for all of you. And we thank the staff for really working so hard to put all this together and to do all the work that goes with all the audit process. Peter, we'd like to thank you as well for being the convener and putting the program together so beautifully. And thank you, Martin Volsleger, for helping us as well in that whole process as well. So thank you to all the speakers. I'll thank them in the start of the day and at the end of the day, but thank you for spending and coming and giving your time so thankfully. So we look forward to what we will hear, and I'll hand back to Peter now. Thank you for coming.